Kat, are you still there?
I am here.
All right, you can go ahead.
Well, hello everyone, and welcome to the Bi-Monthly Coalitions teleconference. My name is Catherine Sheely. I'm from the CDC in Atlanta, and I am happy to introduce today some friends of ours from the USLCA, the United States Lactation Consultant Association. Today presenting, we've got Marcia Walker, who is the Director of Public Policy for USLCA and a board member, and Judy Kadowski is the Chair of the Licensure and Reimbursement Committee of USLCA, and Becky Mantle also is joining us, and she is a past president of ILCA, and she's also a USLCA member, and she has been working with USLCA on creating a position paper on staffing needs related to lactation consultants. So they today are going to be talking to us about improving access to lactation care through legislation and policy. So I'm happy to introduce them, and Marcia, Becky, and Judy, go ahead.
I will start. This is Marcia. I want to welcome everybody and hope that we can give you information that is going to at least let us look a little bit at the importance of improving access for mothers to lactation care and services. Right now there are roadblocks to a lot of women, and what we wanted to look at in this presentation was seeing if there is legislation, policy that could help us, and what U.S. Lactation Consultants Association is doing to help with this particular problem. Next slide. One of the things that is on our side is certainly the Healthy People 2020 breastfeeding targets. This is very exciting because within these targets now there is finally one that looks at that's going to help us improve access to skilled lactation care and services in hospitals, in outpatient settings, in public health settings. Can you go back to that slide, please?
Sorry, Marcia, I'm just trying to get my thing up, but go ahead.
I can't see the slide.
There we go.
That's it. Yeah, this is what we're going to be looking at during this hour. And what we're going to concentrate on, not for the most part, not everything, but for the most part, we're going to look at IBCLC licensure and reimbursement and legislation, policy improvement, these types of things, to see if we can find a strategy or some type of strategic way of improving access through these mechanisms. Next slide. So, if we start with in-hospital access to skilled lactation care, let's look to see how we can improve this. We know that many hospitals have lactation consultants. The problem is many hospitals don't have enough of them. And so access to care is limited in the hospital for a lot of mothers. If you've got a large hospital and only a couple of lactation consultants, if there are 8,000 or 9,000 deliveries per year and you've got 2 or 3 LCs, this is going to limit access to skilled care. If we look at making the case for better access in the hospital, can we make the case to the hospitals? What can we say to them that's going to help with this? Well, if we look at the mPINC data from the CDC, we found that for nursing staff education, that the overall score throughout the U.S. was 65 out of 100, which is very poor. Nobody would want to see their kid's algebra test come home with a 65. Yet 65 is what was scored on nursing staff education. And of course, when moms have their babies, the first people they encounter after that are generally the nursing staff. So we've got mPINC data that can be shown to hospitals that participate, saying that maybe we can improve this. We certainly have the Baby-Friendly Hospital Initiative criteria in terms of what is needed for staff education. Now, both of these are evidence-based recommendations. In other words, it's not just a bunch of us sitting on the telephone here dreaming up what needs to happen. There is evidence for all of this. Any case we make to the hospital for improving staff education has to be evidence-based because it's going to involve the hospital spending time and money on it. Now, nursing staff education regarding lactation is not legislated anywhere. In other words, there isn't a piece of legislation anywhere that I know of that says hospital staff must be educated in lactation care and services. The closest we got in Massachusetts was not legislation, but we thought, let's go around the back door and let's look to see if we can get this mandated as part of our state hospital regulations, in the perinatal regulations that sit in there. Now, every state has hospital regulations that generally are administered through the Department of Public Health. And this is what tells the hospital what they need in terms of the number of sinks, how far the bassinets are apart, how many staff they have to have if they have a level 3 NICU. It's this type of stuff. Now, anything that is in these perinatal or hospital regulations is a mandate upon the hospitals. They have to do this. Next slide, please. In Massachusetts, what we were able to do, and we being the Massachusetts Breastfeeding Coalition, is the Department of Public Health opened up the perinatal and hospital regulations for review. And at that point in time, we were invited in to help craft the recommendations and the guidelines for the mandates that we wanted in there. And what we got put in there was what you can see on the slide here. I've taken this straight from these regulations. Now notice these are regulations, not legislation. We figured if we tried this type of stuff through legislation, it would be shot down very quickly. So we tried going through the use of regulations rather than legislation. So all licensed nursing staff caring for maternal newborn patients shall receive, that means they have to receive, orientation and in-service education that provides training or documents skill in initiation and support of lactation. And then the second piece, at a minimum, each hospital, again, shall provide every mother with advanced lactation support. Can you go back to my slide, please? Thanks. Now, this means that they either have to have an IBCLC on staff to give mothers who need extra help from an IBCLC, or somebody with equivalent training and experience. And unfortunately, that got put in there. We could not eliminate that, but at least we got these two pieces in. Now, what our Department of Public Health does is it visits these hospitals with maternal and newborn services, and it checks to see that the nursing staff is getting the education that is mandated in these regulations. Now, our DPH then issued guidelines or recommendations, and each hospital received the recommendations so that when the assessors from the Department of Public Health go out, they are looking to see that the hospitals have, in fact, done what these guidelines are recommending. So we've tried to improve access to care basically through better staff education and through the mandated availability of either an IBCLC or somebody who's got equivalent training. Next slide. Now, as an advocate for basic staff education, that's what we're doing here. What else can we use? Is there any guidance that we can take to the hospitals when we try to make this case? Well, we certainly have AWHON's policy statements on staff education. We've got U.S. Breastfeeding Committee competencies. Now, this document has just been revised, and I believe is up on the USBC website now. Yes. So that this means that this is a recommendation that everybody have these basic competencies in breastfeeding support or lactation support. So again, this is more ammunition for you to use. Next slide.
Becky.
Go ahead, Becky. Jump right in.
I just like to make the point that coalitions in advocating for improved lactation support in all these areas can make use of the mPINC data, and there is a section in the mPINC data specific to staff education. So each state was given a score on staff education. So study those numbers and be able to cite those numbers when you're working with policymakers and legislators. If you work in a hospital and you're trying to advocate for changes in your hospital and you know what your hospital's individual mPINC scores, then use the data that you have available to make the case. I can say in the state of Oklahoma that our mPINC score on staff education statewide was 47. Well, the health department's appalled at that. And so they have put some funding into staff education for the birthing hospitals in the state of Oklahoma. So you can use that to advocate for change in various ways. Back to you, Marcia.
Thanks, Becky. Next slide. Now we come to looking at some staffing guidelines for IBCLC lactation consultants in the hospitals. We've been looking at this for a long time. There were in the past there were textbooks that came out with recommendations, but there wasn't real good evidence for this. And Becky I think was instrumental in helping put together research-based, evidence-based guidelines in terms of what is really needed to take a look at this. Is it really needed that every single mother be seen by a lactation consultant, or is it necessary that only certain mothers be seen by this? And she went through and looked at all of the various areas that lactation consultants were involved in within each hospital. Then USLCA looked at her data and anything else that was out there and came up with what you see on this slide. These recommendations for the level 3, level 2, and level 1 hospitals, looking at the number of FTEs per 1,000 births, full-time equivalents per 1,000 births. And this is the official recommendation from the U.S. Lactation Consultants Association. And we were very honored that AWAN adopted these guidelines and put these in their own. So you will see this both in USLCA guidelines and in AWAN guidelines for IBCLC staffing within hospitals. Now, most U.S. hospitals are very much understaffed for lactation care. And I live in Massachusetts, and that is certainly true here. We desperately need more lactation consultants and better care in our hospitals. I think, was it Becky or Judy, you put in the Philadelphia hospitals providing IBCLC services? Was that you, Judy?
I did that, Marcia, and
that was talk to that.
That was information courtesy of Kay Hoover, who had done a couple of different surveys of Philadelphia hospitals in those time frames listed to identify who had IBCLCs on staff, and actually, and that was some information I presented at ILCA in a different presentation, but it was astonishing, not surprising perhaps, but still when you see the numbers down on paper, the range of lactation consultant services. Some hospitals, this may sound familiar to many of you, may have had IBCLCs 7 days a week. That's great. Did they have enough? Not necessarily so. And then that ranged from having a lactation consultant 1 day a week or 4 hours a week. So you can see the range of services, and that's our issue, that there are no guidelines on that.
Judy, I have a question on this, actually. If you look at 2007 and 2009, there's a significant drop in these services. Was that accounted for anywhere? Could Kay account for that?
Well, Becky here. Well, we assume that was when the economy tanked.
Okay, so this was something that was seen between 2007 and 2009.
Yes, a number of hospitals eliminated their lactation services.
Right, right.
This is Judy. The other thing that happened in Pennsylvania during that time is that quite a few birthing hospitals closed. So there may have been birthing hospitals that had lactation that were closed, and the ones that didn't have lactation stayed open.
Ah, I got you.
Yeah.
Okay.
Thanks. Next slide, please. Next slide. Megan? Oh, here we go.
Working on it.
There we are. There we are.
Okay, I'll take this one.
Okay.
Then.
Yep. Go ahead.
In my work on developing a position paper on staffing and trying to build a body of evidence, some of you may have responded to this survey that was sent out earlier in 2010, and I've had some statistical analysis performed, and we're in the process of reviewing the results now, and that will be some data that we intend to write up for publication. But I thought for the purpose of this presentation today, it would certainly help make the case. Some of the preliminary analysis that we found through this survey, and this was a survey that was distributed to a SurveyMonkey online survey to all USLCA members, and also to all HCA healthcare hospitals, which is the hospital management company for my hospital in Oklahoma. So I had access to contact all of the hospitals, and that's about 150 birthing facilities in that one alone. And it was a survey of hospital lactation services to kind of get some baseline data on staffing and the demographics of those hospitals and other services that they provided. So some of the initial analysis showed that hospitals with more FTEs, more full-time equivalent positions for IBCLCs, also tended to have higher breastfeeding rates. That was statistically significant in the survey responses. And the hospitals that had more IBCLCs on staff, more positions for IBCLCs, also tended to answer that they had more staff education provided to their nursing staff. So definitely some positive trends there. We asked an opinion question towards the end of the survey. Do you feel that you have, does your hospital have enough IBCLCs on staff to provide optimal breastfeeding care? And 75% said no. That's certainly not a surprise to me with all of the hospital-based lactation consultants that I've interacted with. Now, what was very interesting, too, and very positive trend, was that 25% that did say they felt they had enough IBCLCs on staff also had higher exclusive breastfeeding rates at discharge. So I'm excited to see those trends, and that we'll be able to get that submitted for publication and give us some more body of evidence to make the case for improving our access to lactation care. Next slide, Megan. And I think this all ties in with a number of other initiatives and changes that are coming out. We've certainly seen the Perinatal Core Measures from Joint Commission, which now has the first ever breastfeeding core measure in there for exclusive breastfeeding at discharge. So if we can help make the case that improving your staff education and providing more lactation consultants for breastfeeding mothers and babies, then hospitals are going to improve their outcomes, in particular their breastfeeding outcomes. And once again, look at how your hospital or how your state scored on the mPINC survey and drill down and use those numbers. So, Marcia, I think I'll turn some of this back over to you then.
I put this in because
yeah.
In my travels around the country lecturing, I was hearing so many reports of either lactation consultant hours being reduced or simply the whole program, the whole lactation program being eliminated as a cost-saving mechanism for the hospital. Now, part of approaching the hospital when this is about to happen or when you have heard rumors about this is that this places patients at risk for very poor outcomes. And I have been consulting with hospitals and with people in this situation saying that perhaps they need to approach their risk management department and ask them, by removing the access to this type of care, does this place your patients at risk for turning around and having an outcome that is unintended and that potentially could cause liability to the hospital? Now, if you look at the number of emergency department visits of breastfed babies or mothers, breastfeeding mothers, if you see, when you look at this, if you see a lot of this going on, if you see a continuously increasing amount of this, this indicates very poor lactation care that was received in the hospital. And that, again, is more ammunition to use. It is something that really should be documented. Certainly any of these visits and any readmissions potentially indicate that something was not done correctly during that hospital stay. These, again, are numbers that the hospitals do not wish to see. So it is something that you might want to keep track of to see if this is something you can use in your efforts to either retain these services or improve and increase the services. Next slide. So, if we make the case to the hospitals, we want to check with risk management. We want to make sure that they understand, that administration understands, that withdrawal of these services, either if they're not offered or if they're provided by clinicians who are not adequately trained and prepared to do so, that this could place the hospital and the patient at risk. Now, Shannon Clegg did a survey, and we're going to talk about this a bit later, and this will be published in Clinical Lactation in 2011. She looked at her Intermountain Hospital system, and part of her research showed that 71% of lactation services cannot be effectively performed by bedside nurses. In other words, the bedside nurses should be able to do and have a basic clinical skill set for helping with breastfeeding. But beyond that, mothers really needed access to the expertise of a lactation consultant. And in her study, 71% of these services could not be effectively performed by the nurses. Next slide.
I'll
Becky, this is you.
I'll hop in here, Marcia. This is Becky again. So as Marcia said, the 71% figure from Shannon Clegg's research is very exciting to me, because that correlates with some of the research that I've done as well. And a new publication that will be coming out very early in 2011 is defining the concept of lactation acuity, because I've learned myself in dealing with our hospital administrators and then corporate level hospital management that, you know, we need to speak their language and better define what lactation and breastfeeding support is, what a lactation consultant does, what a perinatal nurse, you know, should be trained to do. And many of us in the healthcare industry are familiar with the concept of acuity and talking about the severity of illness, and we talk about acuity in the ICU, acuity for preterm babies in the NICU, acuity for patients admitted to the emergency department. Well, over the past few years, my lactation team at OU Medical Center and many lactation consultants are constantly doing what we call triaging. When there's never enough of us to see all the patients that need to be seen, then we find ourselves triaging and trying to identify, well, who are the patients that are having the most problems, the most risk factors, the most challenging situations where we need to put our time and energy and resources, and then who are the patients that are what we would consider lower acuity, maybe just need some basic breastfeeding education, reassurance, you know, assessment of latch and so forth. And then that's what we consider lower acuity and what your bedside nurses who are appropriately trained should be able to handle. So, and that helps, I think, better define the needs of our breastfeeding mothers and babies today. So, Megan, if you could move on to the next slide, please. This gets us into, of course, talking about making the case to risk management. So when referring once again to Shannon Clegg's figure, I kind of flipped it in making the correlation with other research that I've done. The 26% of lactation consults that we determined were low acuity, that was presented this July at the OCA conference. And that was information, that was data from 4 different HCA hospitals who have implemented use of the acuity tool, the acuity levels that our group had developed. And we monitored how many breastfeeding couplets were assigned by the lactation consultants, either in level 1, level 2, or level 3. Level 1 being what we considered low acuity, low risk for breastfeeding problems, and that those patients could be appropriately cared for by an appropriately trained bedside nurse, perinatal nurse, and that the other 74-75% needed a higher level of clinical support, or an IBCLC. Well, in the publication I did on staffing in 2006, I also made reference to the reason for consults, the reason that lactation consults were ordered, and I tracked that over a 2-year period of time at our hospital and found that 25% of the time mothers were referred for a lactation consult, and the reason they put was maternal knowledge deficit, meaning we needed some basic education for the mother, and those were determined to be low acuity consults that the bedside nurse could appropriately handle. And then Shannon Clegg in her research, now we're seeing quite a correlation here in that 29% of the time, what I would consider, or my team would consider, low acuity situations that the bedside nurse could handle, and the rest of the time, so now we're in the same ballpark, 70 to 75% of the time, the lactation needs of a breastfeeding couplet are greater than the skill and knowledge and training of a bedside nurse. So next slide, please. Hope that makes sense to everybody. We will be, yes, as I said, submitting that for publication as well, so we can continue to build a body of evidence about the need for lactation support. Now, I think one other point I would like to make on that previous slide, you don't have to go back to that, because I hear this from people too. You know, you've probably heard, I thought breastfeeding was supposed to be natural. Don't you just plop the baby up there? And so how is it that you can say that of all these mothers having babies, that 75% of the time they're going to need a lactation consultant? Well, I think if you take a step back and first look at our mPINC data and determine that the first thing we're not doing is providing an appropriate environment for mothers to be successful. So we are setting up roadblocks and challenges. And then you also have to factor in the increased number of risk factors that we're seeing, the greater number of preterm deliveries we're having, the other lactation risk factors that mothers bring to the table, such as obesity, diabetes, infertility issues, women having babies now who previously weren't successfully getting pregnant and delivering. So we have increased health issues that impact lactation. We could change those numbers if we change our practices in the hospital setting to ensure that more of your mothers and babies are going to be successful. Anyway, so back to you, Marcia.
Next slide, please.
I think she's on it, the outpatient.
Yeah, I'm
This
already
is
on
Judy.
it.
I'll jump in on this one.
Okay. We also have to, I'm giving the message we need to move along very quickly.
Okay.
So we're going to need to go quick.
Okay.
Judy,
So,
you want to do this?
I can do it.
Okay.
The HP 2010 goal of initiation was met at 75%. We know that, but duration rates continue to remain very low. So my part of this talk today has to do more with the outpatient setting. You've heard from Becky, who's the expert on inpatient. When we get to outpatient, unfortunately, the atmosphere is even more dismal for mothers to try and get breastfeeding support. We're looking at when they leave the hospital, how many hospitals provide outpatient lactation support, and how can mothers afford it. Most of those kinds of visits are to breastfeed. Also in the early intervention settings, every one of these NICU babies is referred for early intervention, and an important, it's important for the NICU babies especially who have higher risks to be breastfed, and it's so difficult for these mothers to continue breastfeeding. Most of them leave the hospital still pumping, and the babies haven't transitioned to breast, and there's little or no help for them. So can we go to the next slide, please? We all know here that the public health and the medical professionals do recommend breastfeeding, and they recommend it for a year, and that's going to reduce our health care costs. We do have a new part of the Patient Protection and Affordable Care Act, Section 2713, which states that breastfeeding is a Category B recommendation as a preventive health service, and this is based on U.S. Preventive Task Force recommendations. So we have a little bit of ammunition that we can use there to go forward and ask our hospitals for inpatient and outpatient care of breastfeeding families as a preventive health measure. It's also part of the AAP breastfeeding and the use of human milk policy statement, and Bright Futures, which is the Medicaid component of Medicaid visits that the AAP coordinates and recommends. And these guidelines are not being met by any means across the states.
Judy, let me just pop in a minute. These guidelines are especially important if you're approaching insurers. The insurers need to be looking at reimbursing for preventive services, and breastfeeding now is included as a preventive service. So part of our ammunition is to check that Patient Protection and Affordable Care Act for what the insurers are required to pay in terms of preventive services for breastfeeding.
Thanks, Marcia.
Yeah. Next slide.
So one of the approaches that we are taking to try and improve reimbursement of lactation is to become licensed, and that's very difficult to do. The reason is, there are multiple reasons aside from reimbursement, is that there is a risk of harm to the public. When we talk about licensure, we always want to talk about consumer protection. Mothers, healthcare providers, other people who are involved in caring of the mother, your other healthcare agencies, even community organizations, have no idea what an IBCLC is most of the time. And anyone can say they're an IBCLC or they're a lactation consultant, and they're not an IBCLC, and we have all different levels of expertise, and many of us have heard the war stories or come to pick up the pieces from someone who doesn't have the same kind of skills or experience trying to help a breastfeeding mom. So if we can become licensed and we can tie licensure to the IBCLC, this protects the public because it makes us an identifiable entity for them. They will know what they're getting, and they will know what to look for as employers or as families seeking support, as other healthcare professionals who want to refer to us. It's important for the family to have timely care and be able to find the lactation consultant easily. Even where they exist, it's often very difficult for the families to find you. So that's one of the reasons for licensure. And sometimes within the profession we find resistance to licensure because 80% of our IBCLCs are also RNs, and they have a license under that credential. But no one would go to a doctor or a nurse who is not licensed. That's the way the healthcare professions work in the United States healthcare system. And if we want to have the credibility that the other healthcare professions have, and we want to be referred and understood and acknowledged the same way, we have to be operating on the same system, and that's going to require licensure for us.
Judy,
Can we go to the next slide?
if I can, it's Becky, if I can jump in for just a minute too. Some of the points that we've included here on the slides are basic elements of making the case for licensure or occupational regulation of a particular profession. And so it's not necessarily specific to IBCLCs, but you can certainly see with the points in there about need for timeliness. We need timely care. A breastfeeding mother can't wait a week for somebody to help her with her baby not latching on or not taking in enough milk. So, you know, the elements that tie into licensure of IBCLCs. And, you know, it never ceases to amaze me the other professions that are licensed now. We just got tattoo parlors licensed in Oklahoma. So, anyway, back to you, Judy.
Can I just jump in 1 minute also? Licensure is also tied to reimbursement. If our mothers lack access to the expertise of the IBCLC because the insurers will not reimburse for that, that means mothers who need the help cannot get it because many cannot afford to pay for it.
Right.
So we want to make sure that licensure is understood that it not only protects the public, but it also increases access to care. Can we go to the next slide? We need to keep moving.
Yeah, one other quick point there too, Marcia, is licensure of IBCLCs also does not limit the ability of other healthcare providers to provide lactation care within the scope of their training and practice, but it does identify the IBCLC to the consumer.
Good point. And these points on this slide, I think, are pretty self-evident. One of the many reasons for improving access through the licensure. Can we go to the next slide? Here we talked about that even though there are 2.2 IBCLCs per 1,000 births in the U.S., that doesn't mean mothers have access to these IBCLCs. And so again, this is again a pitch for licensure.
Marcia, if I can jump in, that's no offense to the CDC, but that's one of my most favorite useless pieces of information, I think, that 2.2 IBCLCs per 1,000, because, you know, you don't have any idea, as Marcia said, about the access. But that raises to me two maybe research questions. One, I think, is how many IBCLCs do we need in a state or per deliveries to provide appropriate outpatient care, community post-discharge care, and you know, coalitions and other advocates can perhaps calculate the number of full-time employed IBCLCs in your state. There would be some interesting data to gather. And are you anywhere close to being able to provide what you need on the inpatient side and or the outpatient side?
This slide just looks at the results of lack of access, which is pretty self-evident. Next slide. Right now there is no national licensure system, so all licensing for an IBCLC would be done state by state. And states are very reluctant to create new boards of registration for anything because it's expensive. The thing we're trying in Massachusetts is to place the IBCLC licensure into a related board, such as Allied Health or Nutrition. And U.S. Lactation Consultant Association has hired a consultant and lobbyist to secure licensure in the first state, and that's going to be in Pennsylvania, and that is due primarily to Judy. Judy, do you want to pop in here?
Sure. I'll be working with Scott Harshman. He's our lobbyist, and we're going to put together the strategic plan. We have some things already in our mind, and we're going to be taking those to our local representatives, our state capital, and we're asking all of the breastfeeding proponents in the state to join with us. We will go through the coalitions and the Lactation Consultant Association, certainly be asking for support from other professional organizations as we proceed with this, and working with in Washington, D.C. as well.
Next slide. Judy, do you want to do this real quick?
This is breaking news. We have, as a licensure and reimbursement committee, been working about a year with the National Uniform Claim Commission. We petitioned them first to change the NPI number. There was already one in existence for RN lactation consultants, and that we wanted that to be removed and just have one category for lactation consultants that was defined by the IBCLC. They chose a different way about this. They decided to keep the RN lactation consultant provider number. This is the number that you have to use in any billing transaction for health care to identify your profession, your specialty. So we now have one for RN lactation consultants that's been in existence since 1998, and the new one, which will take effect in April of 2011, and we will have details after January about how to apply for that for you. And that will allow non-RN lactation consultants to also have a provider number that identifies them in healthcare transactions. We're hoping that, using this number along with some other ways that we are trying to educate policymakers and legislators about lactation consultants and what we do, that we can take this information to our state medical insurance commissioners and Medicaid directors. And we want to ask them to start incorporating coverage of lactation services as a preventive service in all of the insurance plans that are available, whether they're Medicaid or whether they're private throughout their states. And we're going to put a toolkit together and ask every one of you in your states to take this to your policymakers so that we can start to get them an understanding of what is needed.
And the last piece down here is that we've been working, USLCA has been working with a set of attorneys pro bono on how to improve Medicaid reimbursement for lactation services. And once we get their final report, we will have a method of doing this. We are hoping that we will be able to meet with federal Medicaid and ask them to distribute a letter to all of the state Medicaid directors recommending that lactation care and services be a covered entity. Next slide. USLCA, in response to much of what we've been talking about, now has 3 new documents that are available on our website. A white paper on reimbursement. Okay, next slide. The 10-second elevator speech real quick.
Okay.
If you had to, in 10 seconds, explain to someone what you're trying to do, you want to say that 75% of mothers are choosing to breastfeed as a preventive health measure as recommended by health authorities. But the mothers can't achieve their goal because they don't have the available qualified breastfeeding support. And IBCLCs are uniquely and ideally qualified to provide this care. If you want to say it in a sentence and then pique their interest, and you can take back these documents that we have on the USLCA website and give them further information, and they're very well referenced. They can follow through on the references for even more detail.
Next slide. And these are recommendations from the U.S. Lactation Consultant Association. These recommendations are found in the new white paper on reimbursement. that is available on the USLCA website for downloading, or you can order hard copies directly from our office. Next slide.
That should be the last one.
And that should be it, yeah.
Go back to the last.
So, are there questions now, Megan? Are we taking questions?
Yes. Can you hear me okay?
Yeah, I can hear you.
Okay. The first question I had, training are the Massachusetts nursing staff required to receive? How much of it is hands-on versus classroom learning, and how are they evaluated?
Okay, the Department of Public Health in Massachusetts does not have those specific guidelines per se written. They don't say that you have to have 90% hands-on and 10% didactic, that type of thing. The DPH assessors do go out and they ask for the number of hours that the nurses have received training, and they have to have the training that is specified in the perinatal regulations. And the DPH has a list of guidelines that I can give you the website for, so you can see how they're being evaluated. If the hospital cannot show that the nurses have this training according to DPH guidelines, then the hospital is dinged for that. And that is something that the hospitals do not want, because that puts them on the watch list of DPH. The DPH then specifies that the training has to occur, and then they will come back and assess again if that occurs.
Another question, how do you think that the Healthy People 2020 objectives will affect the future of lactation at the hospital level?
Oh. You want me to jump in on that one, Martha?
Sure.
I see that as having a huge impact between the Healthy People 2020 and the Joint Commission Core Measure. It's raising awareness, drawing attention to breastfeeding outcomes, which aren't routinely reported by most hospitals around the United States. So if we're starting to shine a spotlight on their breastfeeding outcomes, then I think hospital administrators and leadership are going to start looking at, you know, why are we so low on this list of hospitals? Why are our outcomes so poor in this area, and what can we do to change that? So I see it having a huge impact.
I think many hospital administrators do not know much about Healthy People 2020, and it's a matter of educating administration on the importance of what these goals really are for.
Right, right.
I have several questions about the NPI number, and I think I heard you say that the number and more information will be available after January. Is that correct?
Judy?
Yes, that's correct. You may already have a number as an RN. It is possible for any one person to have multiple NPI numbers. So you may have an RN number. You may have, if you happen to be a physician, after you were an RN, you could have a number for a physician. You can have an IBCLC number. So we'll be getting a lot of details for you on how to obtain that number, and then how you'll use that in combination or alone with other credentials.
And that's a national provider identification number, so that identifies that person as a billable provider of healthcare services in whatever.
And this is what this is so important, because what we are trying to establish is the IBCLC as a billable provider of lactation care and services. And ultimately, of course, this is good for the profession, but it also increases access to care for the mothers who need it.
Right, right.
A couple of related questions. One is, does the Public Health Department in all states have the jurisdiction to regulate hospital regulations?
As far as I know, the Department of Public Health, there is some entity in every state that regulates hospitals. Mostly it's done through the Department of Public Health. Now, I'm not going to go on record as saying every single state, because I don't know. I know that is certainly done in most states. If you have a question about that, you should ask your own state public health department if they regulate hospitals or who within the state healthcare system does so.
Okay. I have another question. Will there be a separate test for the state licensure?
This is Judy. That will depend on how the legislation would be written. Licensure must be done via legislation. So it depends on the bill, who writes it. Our model legislation that we have in USLCA would tie licensure to the IBCLC credential, which would not require an additional exam, thus saving a lot of money and making licensure a lot more possible to happen, because if we had to create another exam and administer it, it might make licensure cost prohibitive. We don't have enough practitioners to support that in any individual state.
Okay. This is a question about the Category B recommendation in Section 2713. Can you expand on the significance of this category?
That category is important because it tells the insurers. Now this applies to, oh Judy, refresh my memory. Is it public or private insurers? It's one or the other. It's not both. I think it applies only to private insurers.
Yes.
I don't think it applies to Medicaid. It's in our publication. That particular piece is the piece in the Health Care Act on preventive care, and preventive care was a big piece of that act. So because breastfeeding has been identified as preventive care, it means that private insurers need to be paying for that. So we would want to look very closely at that when we are talking with insurers. If you look at our white paper on reimbursement, that explains it a little bit further. And it should help you, it should help guide you when you're talking with the insurers, saying, look, this piece is required now to be covered. Does your insurance coverage reimburse for this preventive service?
Marsha, I believe it's for the private insurance plans.
It is, yeah, it is. It's private.
It states pre- and postnatal breastfeeding education, formal breastfeeding evaluations undertaken by trained caregivers in the hospital and outpatient care settings, followed by interventions to correct problems as needed. And as you can see by that definition, the IBCLC is the person who is going to be important in providing that care.
Right, because the IBCLC meets those requirements.
Okay, there are a number of questions. I do want everyone to know that we do keep a log of all the questions. The system will give that to us, including your email addresses, so we can answer a few others by email afterwards. Okay. I don't know, Kat, how we're doing on time. Do we want to switch over to announcements?
Well, we recognize that everyone has a lot going on, especially this time of year, and we are very close to being at the 3 o'clock Eastern time hour. We have very few brief announcements. I wonder if there was, if you skim those questions, if there's one, burning question that you anticipate lots of people on the call might want to hear, maybe one last question, and then we'll switch over.
Well, if we're running out of time, can we answer them through email or on the website?
Yes, we can. That's something we did with the previous call, where the two speakers were set the questions, and they can do that by email. And if there are ones that are burning questions that we think will be relevant to many, we can also post them on the webpage.
Sure.
Okay.
I mean, I think all three of us would be most happy to answer any of those questions.
Mm-hmm.
Sure. Yeah, that'd be great.
Well, in that case, thank you very much, Marcia, Judy, and Becky. Really appreciate it. I know this is a lot of information. I anticipate this is probably a slide that people are going to keep on hand so they can refer to it later. And so I'm going to switch over to Larry, who has very few notes.
Just a couple of very brief announcements, and they may be things that you're all already aware of anyway, but just wanted to make sure that they got out there. First is that, as was mentioned on the call here, Healthy People 2020 objectives for breastfeeding were released on December 2nd. They are available to anyone who wants to see the full gory detail of how they're being measured and what the targets are. If you go to www.healthypeople.gov, all of the information are there. You can go to the maternal and child health section within that to find the breastfeeding indicators. Just briefly, they are the same indicators that we've used for Healthy People 2010, but all of the targets for the next decade are higher than they were to date. In addition, we've added 3 more kind of process indicators of how we're going to achieve those increases in breastfeeding behavior, and those refer to optimal care in our hospitals, formula supplementation in the first 2 days of life, and accommodations for breastfeeding in the workplace. So I think the key function here is that not only are we saying these are good things to do, but at the national level we're going to be tracking our progress on a year-by-year basis towards those. Hopefully what gets measured gets done, and so we'll get a lot more focus on these particular process indicators to really improve the kind of support we provide our breastfeeding mothers. The second announcement I wanted to make today was that we now have formal approval for conducting the 2011 mPINC survey. So CDC will be carrying forward with that. Thank you to those of you who sent in comments to the OMB that helped us acquire that approval without any glitches this year. So that's all I had for announcements. Thank you. Megan, I don't know if there are any announcements from USBC.
Yes, I just have a couple of very quick announcements. If you're still viewing the webinar, you hopefully can see a copy of our homepage at www.usbreastfeeding.org. I know many of you have received email announcements this week from us, and I wanted to make sure that you all knew that our 2 new publications are posted right on the homepage. We already referenced the core competencies in breastfeeding care for all health professionals. That is posted right here in the news box. And also we have updated and re-released our toolkit implementing the Joint Commission Core Measure on exclusive breast milk feeding. We had originally published it in January with Section 1 with guidance for the data collection piece. We have added a new section to the document that is focused on implementing best practices to improve the exclusive breast milk feeding outcomes. So we encourage you to take a look at that and to share it with hospitals in your states and in your areas. And also, when there is a feedback survey as well. When you click on the link, you'll be able to give us some feedback on the toolkit and how useful it may be for hospitals that are using it. So please do check those out. The other thing I wanted to make sure everyone knows that there is this handy little quick link over in the quick links box for the bi-monthly coalition's teleconferences. That's a fast way for you to get to the information about these teleconferences for next time, as well as the previous teleconference. The dates of the next one will be posted here, and then down here at the bottom you can see the archives of the previous years and teleconferences. So please do check that out. We will post the recording as well on those pages, and let others know if they weren't able to be here today that they can view the recording and the slides and handouts on the website. I think that's the other major announcement. I want to make sure everyone knows that we have set a date for the 2012 Coalitions Conference. We will be sending out a more formal announcement about this, but for those of you who are on the call today, it will be in August, actually, of 2012. So it will be August 4th through 6th of 2012. We did decide that, especially because of the risk with the weather situations in January, that it was prudent to move to August. So August 4th through 6th, 2012, and we will be sending out further announcements about that as we get closer. But that's it from me.
Yeah, Megan, one other thing, the documents that we were talking about from the U.S. Lactation Consultant Association are all available online at uslca.org. Thank you.
All right, Kat, are you still there?
No, Kat had to leave. Unfortunately, she has another call. So I think Megan, we can end.
Yeah,
I think we've gone a little over our time.
Yeah. So everyone that, as you know, you'll go ahead and hang up from this call and disconnect from the webinar. And then if you are going on to the regional call, there's a separate number for that. So we will go ahead and sign off. Thank you, everyone.
Thanks, everyone.
Thank you, Megan. Thank you, everyone.
Thanks, ladies. Take care.
Bye-bye.